Welcome to the deep dive. When you think about osteoarthritis, well, for most of us, it probably brings to mind older people, aching knees perhaps, maybe just that unavoidable bit of wear and tear that comes with a long life.
That's the common perception, yes.
But the research we're digging into today paints a really quite different picture. It's, frankly, quite an urgent story.
It is indeed.
It shows osteoarthritis not just as an older person's disease, but something that's actually having a significant impact on younger, active people.
Often triggered by injuries. That's a key point.
And it comes with a pretty hefty price tag, too, doesn't it? Personally, but also economically.
Absolutely. The costs are substantial.
So we've gathered research papers looking at, well, everything, really. From those subtle early signs, the microscopic changes happening inside the joint, right through to the sheer numbers who's affected, the financial fallout.
The underlying biology, which is fascinating.
And of course, what we're actually doing now, and maybe hoping to do in the future, to treat it. So our mission in this deep dive is simple, really. We want to cut through all that complexity, pull out the most important insights from these, let's face it, quite technical sources.
They take it dense, yes.
And give you the clear, actionable knowledge you need to get up to speed quickly on early OA. You know, what it is, why it's hitting younger people, what it really costs, and where the science is heading.
That's right. And it's absolutely crucial, as you said, to understand that we're distinguishing early osteoarthritis, early OA, as a specific thing.
Right. It's not just the start of the end-stage disease.
Precisely. It's not just the very first twinge of late-stage disease.
Right.
Being able to accurately define this early phase, both clinically by what we see and structurally what's happening at a tissue level, that's the real key.
Why is that definition so important?
Because it's how we identify those people at highest risk early on. And that's when intervention, treatment, has the greatest potential to actually make a difference. The sources we looked at highlight that there's been quite significant progress recently in refining this definition, moving beyond just looking for changes you might see on a standard X-ray.
Right, looking deeper. Let's unpack this insidious phase the papers describe. What does that actually mean for someone who might be developing early OA?
Insidious. Well, it basically means it's often subtle. It can almost sneak up on you.
Not dramatic.
Not usually, no. Compared to someone with advanced OA, who might have constant, quite severe pain, patients in this early phase can be largely asymptomatic.
So feeling nothing at all?
Potentially, yes. Or they might have symptoms, but they're reduced. Maybe lower intensity pain, perhaps a bit of stiffness, but not necessarily there all the time.
And the type of pain is different too, isn't it? I found the description in the sources quite interesting.
Yes, it is distinct. In early OA, the pain is typically mechanical, so it's related to activity.
Right.
It's often described as a sort of deep ache, maybe not always easy to pinpoint exactly where it's coming from.
Any specific activities mentioned?
Yes. The sources specifically point to weight-bearing activities that involve loading and bending the joint. Things like using stairs. That's often one of the first things people might notice pain with.
Okay, stairs. That's quite specific.
And it's a stark contrast to advanced OA, where the pain can become constant. It might wake people up at night. It's significantly worse with activity, though it might ease off a bit with rest.
So very different profiles.
Very different. And there's even uncertainty acknowledged in the sources about whether someone who feels completely pain-free might actually already have underlying early OA changes happening silently.
That pain-free but changes happening idea, that really sticks with you, doesn't it? It highlights just how subtle this can be.
It does.
So if the clinical signs are minimal, what about the physical changes inside the joint? Where do they actually start?
Well, according to these papers, the primary sites of change in early OA are the articular cartilage.
That's the smooth lining on the bone ends.
That's the one, yes. That smooth surface. And the subchondral bone, which is the bone directly underneath the cartilage.
Okay, cartilage and the bone beneath.
But, and this is important, it's not just those two. The sources are very clear. Early OA is a whole joint disease.
Not just wear and tear on one surface, though.
Absolutely not. It affects all the structures in the joint. The synovial membrane, that's the lining, the interpatellar fat pad, the menisci, the shock absorbers, the joint capsule, the ligaments, even the surrounding muscles. Changes are happening across the board, right from the early stages.
Wow, okay. So it's systemic within the joint. Is there a way researchers actually grade these early changes, particularly in the cartilage?
Yes, there is. The ORSI histopathological grading system is key here. It looks at microscopic changes in the cartilage tissue itself.
Microscopic level.
Exactly. And the grade is particularly relevant for early OA because it reflects the depth of the damage. It starts at the surface and progresses inwards.
So how deep the problem goes?
Precisely. You might see early disruption just on the surface, maybe tiny cracks or what they call fibrillations.
Fibrillations.
Like tiny fraying.
Yeah.
And eventually, you might see vertical fissures starting to extend down into the middle zone of the cartilage layer.
Okay.
This grading focuses on the area with the most advanced damage, even if that area is quite small to begin with.
And you mentioned stage as well. How is that different?
The stage is about the horizontal spread. So how much of the joint surface area is affected, grade is depth, stage is spread across the compartment, and they're considered independent of each other.
Got it. Grade for depth, stage for spread. And you said the bone underneath is changing early, too.
Correct. The subchondral bone shows changes right from the start. There's a progressive thickening of the subchondral plate. That's the very dense layer right under the cartilage. And also structural alterations happening, the spongiosa, the more porous spongy bone just below that.
So changes happening at the same time, cartilage and bone?
Yes, simultaneously. In the cartilage layer and the bone supporting it, it's a coupled process.
Given how subtle the symptoms can be and how early these changes start, I'm guessing standard imaging like a regular X-ray or even a normal MRI isn't brilliant at picking this up.
That's precisely the challenge. The sources explain that conventional morphological MRI, which is what's typically used in clinics.
The standard scan.
Yes, the standard scan. It often misses these very early changes in the cartilage. Things like the initial loss of key molecules in the matrix.
Like what?
Like glycosamine glycans or gags, which hold water, and also the initial loosening of the collagen network. These things can happen when the cartilage still looks, superficially, pretty normal, or maybe only minimally changed on a standard scan.
So you need something more sophisticated.
Absolutely. This is where the advanced MRI techniques come into play. Methods the sources refer to as pre-structural cartilage assessment.
Pre-structural. So seeing changes before the structure visibly breaks down.
Exactly. Techniques like T2 mapping and DGMR. T2 mapping, for instance, can detect subtle changes in the water content and the organization of the cartilage matrix that signal early degeneration, even before you see thinning or defects.
That's clever. How does it work?
Well, T2 values relate to water mobility and collagen structure. The sources reference data from the big Osteoarthritis Initiative study.
The OAI.
Yes, the OAI. It showed subtle but significant differences in T2 values between healthy knees and those with early signs of OA on X-ray, or even knees just considered at risk. This suggests the technique can pick up early differences that might be linked to risk factors.
Fascinating. Almost like seeing a biochemical footprint the standard MRI can't. And what about DGMRI? That uses a contrast agent, right?
Yes, DGEMRI, that stands for Delayed Gadolinium Enhanced MRI of Cartilage. It uses a negatively charged contrast agent.
Oh.
Healthy cartilage has lots of negatively charged gags, which repel the contrast agent. Where gags are depleted, in early OA, more contrast agent can diffuse in.
Ah, so less gags means more contrast signal.
Exactly. By measuring how much contrast agent gets into the cartilage after a delay, you can indirectly measure the JAG concentration. Lower JAGs mean more contrast uptake, indicating early degeneration before you might see structural loss on a normal scan. These advanced techniques are really pushing the frontier of detecting the disease much, much earlier.
It's amazing what they can see now. The sources also mention a whole host of different scoring systems that researchers use with MRI, alongside the older X-ray methods like Kellgren-Lawrence that people might be more familiar with.
Yes, it's a bit of an alphabet soup, isn't it? You see Mayo-X, Worms, ACLOAS, Kimbrus mentioned for MRI.
Right.
And then the familiar Kellgren-Lawrence IKDC-Albeck scales for X-rays. The key point the sources make here is that there's actually quite a lot of variation in these different assessment tools, especially the semi-quantitative MRI ones.
Oh, so?
Well, they divide the joint up differently. They grade features in varying ways. This variability isn't just an academic detail. It can genuinely affect the outcomes reported in different studies.
Ah, so it makes comparing research harder.
Exactly. It makes comparing findings across different studies quite challenging, especially when you're trying to track subtle changes in early disease progression. Consistency is key, and we're still working towards that.
Okay, so early OA is subtle, involve specific tissue changes in the whole joint, and needs advanced tech to really see it early. Now let's really focus on who is getting it early. The sources make a very strong case for post-traumatic osteoarthritis PTOA.
They really do. They highlight PTOA of the lower extremity, so hip, knee, ankle as a major pathway. They often refer to it using phrases like the premature aging of youthful joints.
Premature aging. That really shifts the narrative, doesn't it?
It fundamentally changes it. It moves away from just thinking about age-related wear and tear to a narrative driven significantly by joint injury, often happening in younger, quite active populations.
And the statistics provided, particularly around common injuries like ACL tears and meniscus tears, they're quite stark, actually.
They really are. The data presented is compelling. If you rupture your anterior cruciate ligament, your ACL, or tear your meniscus, or maybe even both.
Which often happens together.
Which often happens together, yes. You face nearly a 50% chance, a coin flip, basically, of developing symptomatic OA within 10 to 20 years of that initial injury.
50%. Within 10, 20 years, that's huge.
It's huge. And given that most people who tear their ACL are under the age of 30.
Right, it's often younger athletes.
Exactly. This means a significant number of people are being diagnosed with PTOA before they even turn 50. That's roughly 5 years earlier than the average age of OA onset in the general population, which is around 55.
So it's bringing the onset forward considerably.
Considerably. The sources mention athletes sometimes showing signs as early as their 30s. There's a key study by Lohmander and colleagues often cited.
Yes.
They looked at female soccer players 12 years after an ACL reconstruction. They found radiographic OA, so visible changes on X-ray in the injured knee, in over half of them, 51%.
Over half.
Compare that to their other uninjured knee, only 8% showed OA changes. That difference is massive.
51% versus 8%. That's a powerful illustration of how much that injury drives the process.
Absolutely.
Beyond that first injury, the sources also talk about how common recurrent ACL injury is and the risk factors linked to it.
Yes, recurrence is a really significant concern, and unfortunately it happens quite frequently.
More common than people might think.
I think so. The sources point to various risk factors, but sport type and the level of competition really stand out.
Higher level, higher risk.
Seems so. Data from the Moon Group, a large U.S. cohort, showed similar risks of re-injuring the surgically reconstructed knee and injuring the opposite knee within just 2 years. Another study cited looked at NCAA university athletes and high school athletes.
Okay.
It found an 8.7% recurrence rate overall. But the NCAA athletes faced a 4.6 times higher likelihood of a recurrent injury compared to the high schoolers.
4.5 times higher at the NCAA level. So the intensity and demands of those higher level sports significantly increase the risk of re-injury.
It appears so.
Do they mention which sports had the highest rates?
Yes. According to a 10-year NCAA study cited, the highest recurrent rupture rates, when measured per athletic exposure, were in men's American football, women's gymnastics, and women's soccer.
Okay. Interesting mix there.
They also noted that non-contact recurrent tears, so not from a direct hit, were more common in the preseason or postseason periods, training phases perhaps.
Right. Maybe when conditioning isn't quite optimal.
Could be. Interestingly, while men overall had a higher rate of recurrent rupture in that particular data set, the ratio of recurrent injuries compared to primary injuries actually decreased for both genders over the study period.
Oh. What might that suggest?
Well, it perhaps suggests some improvements over time in prevention strategies or maybe surgical techniques or rehabilitation.
Yeah.
Although the absolute risk clearly remains significant.
So repeated injury, or maybe just playing certain sports at a very high level, keeps that OA risk elevated. What about meniscus injuries? The sources are very direct about that link. One quote says, "The relationship between meniscal injury and OA is plain to see,"
with considerable literature reporting their strong association. Yes, that quote really highlights the consensus in the field. A meniscal injury immediately fundamentally alters the joint environment.
How so?
The sources explain that the OA cycle begins very early after injury, often at a cellular and biochemical level, even before the mechanical changes become really obvious.
So change is happening unseen.
Exactly.
Right.
When the meniscus is damaged, it loses its ability to perform its vital functions, distributing load evenly across the joint, absorbing shock, providing stability. And this mechanical failure essentially accelerates the breakdown process that leads to OA. The greater the initial damage to the meniscus, the more impaired its biomechanical function becomes, and generally the faster the OA progression.
Are certain types of meniscus tears worse than others for triggering OA?
Yes, the research points quite strongly in that direction. The sources specifically call out meniscal extrusions.
Extrusions, what's that?
That's where the meniscus sort of gets squeezed out from its normal position between the bones. That and large radial tears that run across the width of the meniscus.
Right.
These seem to be the most significant contributors to the onset and progression of OA.
More so than other tear types.
They note that smaller tears, perhaps like longitudinal tears running along the length of the meniscus, might have less dramatic initial biochemical effects, which perhaps means their long-term OA risk might sometimes be underestimated.
Okay. And what about surgery? Specifically, removing torn meniscal tissue, a meniscectomy. How does that impact the joint long term?
Well, the sources are pretty clear on this. Meniscectomy, especially removing a significant portion, significantly accelerates degenerative changes in the joint.
Even if it helps symptoms initially?
Yes, that's the paradox.
Hmm.
Studies with long-term follow-up show clear radiological progression of OA after meniscectomy, even if patients report feeling much better clinically in the short term.
Any specific studies mentioned?
The Paradowski study is cited as a prime example. It followed patients for nearly 25 years after meniscectomy.
25 years.
Yes, a long time. It showed a much higher incidence of OA, both in the main tibiofemoral joint and behind the kneecap, the patellofemoral joint, as well as other structural changes in the operated knee compared to the unoperated knee.
That's compelling long-term evidence.
It is. And a more recent study also found significant OA progression after arthroscopic partial meniscectomy, just removing the torn part, particularly noting higher risk in patients with a higher BMI and those with degenerative tears rather than acute traumatic tears. They point out this finding actually goes against some of the previous literature, which sometimes suggested degenerative tears were less problematic.
So it seems even partial removal carries a significant long-term risk. It sounds like while meniscectomy might fix immediate symptoms, you're potentially borrowing from the future health of the joint.
That's a very good way to put it. It's the difficult trade-off that's highlighted. The sources strongly conclude that patients with any significant meniscal injury should be considered at high risk for developing OA down the line.
So what's the implication for treatment then?
It emphasizes the need for treatments that are really focused on restoring the meniscus's integrity and function whenever possible. So repair rather than removal, if feasible. But they also know that even surgical treatments, whether it's a repair or a partial removal, still carry an increased OA risk compared to a completely healthy joint.
So no easy answers.
No easy answers. Deciding how to manage a tear requires very careful consideration of the individual patient, their activity level, their age, and the specific characteristics of their tear.
Beyond the ACL and meniscus, the sources briefly mention intra-articular fractures breaks that go right into the joint surface as another cause of PTOA.
Yes, IAFs are acknowledged as contributing to the risk of developing PTOA. The sources state that while this link is known, we actually need more research to better quantify the risk associated with different fracture types and patterns.
And to develop better treatments.
Exactly. To develop and implement treatments that can truly mitigate that risk and prevent or delay PTOA in these often complex injury cases.
Okay. So we've firmly established that injuries are a major driver of early OA, particularly in younger active people. Why is this becoming such a significant problem, especially from an economic perspective, hitting people who are often in their working prime?
This is where the picture really broadens out beyond just personal health to become a major societal and economic challenge. Unlike many older OA patients who might already be retired, these younger individuals are typically right in the middle of their working lives, often with decades of career ahead of them.
So the impact isn't just the direct medical cost, it's about lost productivity, isn't it?
Exactly that. When a younger adult develops debilitating pain and the limited mobility that can come with OA, it severely impacts their ability to work effectively, or sometimes to work at all.
Leading to time off, or even leaving work altogether?
Yes, it significantly increases their risk of having to withdraw from the workforce early. The sources cite a really striking statistic.
What's that?
That arthritis, and OA is the most common form, increases a person's risk of being out of the labor force entirely by a staggering 64%.
64%. That's a massive potential impact on someone's career path and financial stability.
It's huge. And the sheer number of lost workdays nationally, it's immense.
How immense?
The United States Bone and Joint Initiative's 2016 report found that adults with osteoarthritis reported something like 180.9 million total lost workdays just between 2013 and 2014.
180 million.
And to put that into sharp relief, that figure represented 34% over a third of all lost workdays reported for any medical condition during that period.
A third of all lost workdays across all conditions, just from OA. That statistic alone should make employers, policymakers, everyone really pay attention.
It's a staggering figure. It highlights that OA is a leading cause of lost work time and productivity, full stop.
And the direct medical costs involved? Are they higher for younger patients too?
They were, according to the McLean et al., data cited in the sources. Even back in the early 90s, they showed higher direct medical costs per year for patients under 65, around $2,800, than compared to those over 65 who are closer to $2,000 per year.
Why would that be?
Well, the reason this translates into what the sources called hefty cumulative costs over a lifetime is simply because these younger patients live with the disease for so much longer.
Ah, right. More years of needing treatment.
Exactly. An older patient might develop OA and live with it for, say, 10 or 15 years. A younger patient diagnosed in their 30s or 40s could have it for 30, 40, even 50 years, accumulating medical expenses, needing potentially multiple interventions over that entire extended period.
So for our listeners, many of whom are professionals navigating their own careers, this isn't just about potentially managing a future health issue for themselves, maybe decades down the line.
No, not at all.
It's about understanding a force that significantly impacts workforce productivity right now, affects career longevity, and has major implications for long-term financial well-being, both for individuals and for the organizations they work for.
That's a critical point to grasp. The economic burden of early OA in younger, working-age individuals is a major concern that affects employers, healthcare systems, and national economies, not just the person with the sore joint. Understanding this broader impact is vital for informed planning and resource allocation.
Okay, we've covered the subtle symptoms, the strong link to injury in younger people, and this huge economic cost. Now, let's really get into the science behind it. The sources fundamentally challenge that old idea of OA being just simple wear and tear, don't they? They position it much more as an inflammatory process.
Yes, this shift in understanding has been a really big development gathering pace since the 1990s, largely driven by advances in molecular biology. The old purely mechanical view was just too simplistic.
So inflammation isn't just a side effect.
No. The evidence presented here from multiple studies strongly points to inflammation within the joint, specifically inflammation of the synovial lining, synovitis, as a crucial feature of early OA pathology. It's not just something that happens late in the game. It seems to be part of the core disease process right from the beginning, especially after injury.
How does this inflammatory process actually work then? How does it break down the joint?
Well, it involves a pretty complex chain reaction. Damage or injury triggers the release of molecules within the joint that shouldn't normally be floating around freely, bits of damaged matrix, for example.
Danger signals.
Exactly. They act as danger signals, or what scientists call alarmins. These activate the innate immune system cells that reside within the joint tissues. This activation leads to a cascade involving the production of inflammatory mediators and destructive enzymes. Key players include enzymes that degrade the extracellular matrix, the stuff that holds cartilage together. Things like MMPs, matrix metalloproteinases, and ADAMTS enzymes.
They chew up the cartilage.
Essentially, yes. They break down important components like aggrecan and collagen. At the same time, the cartilage cells themselves, the chondroites, get switched into a catabolic state. Meaning they start producing more of these breakdown enzymes and fewer the molecules needed to maintain the tissue. They shift from building and maintaining to breaking down. This is driven by factors like inflammatory cytokines, signaling molecules like interleukin-1 and TNF-alpha, and prostaglandins, which are released in that inflammatory environment.
And the sources mention specific molecular pathways being switched on, like NF-κB?
Yes, the activation of transcription factors like NF-κB is seen as a central event in this process. When NF-κB gets activated in cells within the cartilage, the bone, and the synovium, it essentially tells those cells to ramp up production of a whole host of inflammatory mediators, TNF-alpha, IL-1 beta, IL-6, and others.
Creating a hostile environment.
Precisely. It creates this hostile inflammatory environment within the joint that accelerates tissue damage. It also leads to the excessive generation of reactive oxygen species, ROS.
Free radicals.
Think of them like damaging free radicals, yes. This causes oxidative stress, further tissue damage, and contributes to a kind of accelerated cellular aging or senescence within the joint tissues.
It sounds like a vicious cycle.
It really is often described as a feed-forward catabolic cycle. It involves all the joint tissues feeding into each other's dysfunction, and the evidence for this is overwhelming. You find elevated levels of these inflammatory markers in OA joint tissues and in the synovial fluid. And synovitis, that inflammation of the joint lining, is consistently present, even in the early stages of the disease.
So it's a destructive cycle really powered by inflammation. Are there particular inflammatory signals or specific immune cells that seem especially important in early OA? Perhaps areas where intervention might be possible to break that cycle?
Yes, interleukin-1, or IL-1, is definitely highlighted in the sources. They note that particularly after an injury, there seem to be relatively unopposed increases in IL-1 activity within the joint.
And IL-1 is bad for cartilage.
It's strongly catabolic, yes. It drives cartilage breakdown. And levels of its natural inhibitor, IL-1 receptor antagonist or IL-1RO, seem to decrease as cartilage damage gets worse. Laboratory studies also show that the superficial layers of cartilage are particularly vulnerable to damage induced by IL-1.
Does this biochemical finding link back directly to how patients actually do, to the outcomes we talked about earlier?
Yes, there's compelling evidence suggesting it does. The sources cite studies showing a direct correlation. Levels of inflammatory cytokines like IL-1 alpha and cartilage-degrading enzymes like MMP9 measured in the joint fluid on the very day someone has ACL reconstruction surgery.
Right after the injury and surgery.
Exactly. Those levels actually correlate with the amount of cartilage change seen on MRI scans 3 years later.
Wow.
And perhaps more importantly, higher levels of these inflammatory markers measured at the time of surgery were associated with worse patient-reported outcomes down the line. Things like lower quality of life scores, more pain, poorer function.
That's powerful. It suggests the inflammatory environment present right from the start isn't just a temporary blip. It seems to set the stage for long-term problems.
It really does. It indicates that this early heightened inflammation can lead to issues like recurrent joint swelling, persistent synovitis, and ultimately continued cartilage breakdown with long-term consequences.
The sources also discuss the role of specific immune cells, don't they? Particularly T cells and macrophages.
Yes, the chapter focusing on T cells makes point of stating its focus is on their role in early OA.
Why?
Because that's really the window of opportunity where we might actually be able to intervene effectively to prevent or truly modify the long-term disease course, rather than just managing late-stage symptoms.
Makes sense. How are T cells involved?
Well, damaged joint cells release chemical signals, chemokines, that act like beacons, attracting T cells from the bloodstream into the inflamed joint. Different types or subtypes of T cells seem to be involved.
Different jobs.
Broadly, yes. And the specific mix of cytokines already present in the joint environment influences which T cell types are recruited and what they subsequently do. Some might promote further inflammation, while others could potentially help to resolve it.
Which subtypes are mentioned?
The sources mentioned the general subtypes people might have heard of: Th1, Th2, Th17, and Tregs, and their broad functions. Th1 cells, for example, often associated with activating phagocytic cells, Th2 with responses to parasites, Th17 with bacterial defense, and Tregs are generally immunosuppressive.
But it's complicated in OA.
Very. The sources stress that the exact interplay between these different T cell subsets within the OA joint environment is still being unraveled and needs much more research. Understanding that interplay is crucial if we want to develop targeted immunotherapies that could work early in the disease process.
Okay, so T cells are players, but the details are still being worked out. What about macrophages? They're major immune cells too.
Macrophages are definitely key players. They are known producers of inflammatory mediators like TNF-alpha. One animal model study mentioned showed that after an ACL injury, there were increased levels of a molecule called macrophagin inflammatory protein 1 gamma, MIP1, in the joint lining, the synovium.
MIP1 gamma, what does that do?
Well, it acts as a potent chemoattractant, recruiting other inflammatory cells to the site. But interestingly, it also influences bone resorption by regulating osteoclasts, the cells that break down bone.
Ah, so linking inflammation and bone changes?
Potentially, yes. A study cited demonstrated that a specific type of T cell, the CD4 plus T helper cells, seemed to influence OA progression, partly by regulating this MIP1 production.
How did they show that?
In a mouse model, silencing the gene for MIP1 actually reduced the infiltration of immune cells and macrophages into the joint after injury. It also lowered inflammation markers like IL-1 expression, decreased the number of bone-resorbing osteoclasts, and ultimately reduce the amount of cartilage damage.
So targeting MIP1 could potentially interrupt both the inflammatory cascade and the associated bone changes. That sounds promising.
It suggests it could be a potential therapeutic target, yes.
Yeah.
Though obviously translating that from mice to humans is a big step.
Of course. It's clear the biology is incredibly complex and highly inflammatory. But can we really separate that entirely from mechanics? How does mechanical load, the forces going through the joint, fit into this inflammatory picture?
This is a really critical intersection that the sources explore in detail, and it has huge implications for things like rehabilitation and advising people on activity levels.
How so?
Well, firstly, they cite studies showing that very high-intensity, sudden impact loading like a jump landing perhaps can actually cause chondrocyte death directly.
Just kill the cartilage cells.
Yes, through a specific cellular pathway involving the mitochondria, the cell's powerhouses, and the production of those reactive oxygen species, ROS we mentioned earlier. It suggests that sheer force can trigger a kind of biologically programmed cell death. It's not just physically squashing them.
That's a direct biological link between excessive force and cell death. Is it preventable?
Intriguingly, in laboratory settings, yes. Disrupting this specific pathway, for example, using a simple antioxidant compound, markedly decreased the ROS levels and the amount of cell death observed after impact loading. This points towards potential protective strategies, although applying that in vivo in a person is another matter.
Still fascinating. What else about mechanics?
The sources also note that after an injury like an ACL tear, people often develop altered movement patterns. They might subconsciously avoid loading the injured leg, leading to underloading. Or they might compensate in ways that actually overload other parts of the same joint, or the other leg, during activities like walking, running, or squatting. And these abnormal loading patterns are strongly linked to subsequent degeneration in both the cartilage and the underlying bone.
So altered mechanics drive degeneration.
Yes. And furthermore, even in what we call idiopathic OA, the type not directly linked to a major injury-altered mechanics resulting from previous, maybe minor injuries or alignment issues, can accelerate the disease process.
And this brings us back to that really crucial finding you mentioned earlier about the difference between high-impact versus low-impact loading and inflammation.
Yes, this is foundational for thinking about activity. The research suggests that high-impact loading seems to have the potential to actually increase pro-inflammatory activity within the joint, specifically by activating that NF-κB pathway we discussed.
So heavy impact can ramp up inflammation.
It appears so. Conversely, lower intensity loading, more gentle, controlled movement appears to decrease this inflammatory activity.
That's a critical distinction.
It really is. This isn't just about avoiding physical damage to the tissue. It's about how mechanical forces directly influence the biological environment and the inflammatory signaling within the joint. This has profound implications for how we design rehabilitation programs after injury and how we advise patients on returning to activity. It strongly suggests that the quality and intensity of the load placed on the joint matters significantly for its long-term biological health, not just its mechanical integrity.
That connection between specific mechanical loads and the underlying inflammatory pathways, that feels like a major takeaway. It suggests rehab isn't just about restoring strength and movement. It's potentially about actively managing the biological environment through movement.
Precisely. It opens up a whole new dimension to therapeutic exercise.
Okay, let's shift gears now and talk about treatment strategies. Given this complex, evolving understanding of early OA, the inflammation, the mechanics, the injury link, what approaches are currently being used or perhaps being explored for the future?
The sources cover a pretty wide range, starting logically with non-surgical options, which are often focused on managing symptoms initially. Pain management is obviously primary.
What are the main options there?
Well, simple analgesics like acetaminophen, paracetamol are noted as having a good safety profile, especially for older adults or those with stomach issues, but they lack a direct anti-inflammatory effect.
Compared to NSAIDs?
Compared to nonsteroidal anti-inflammatory drugs, NSAIDs, yes. NSAIDs can reduce inflammation as well as pain, which might be advantageous, but they carry other risks like gastrointestinal or cardiovascular side effects, particularly with long-term use.
What about supplements? Do they get a mention?
Oral vitamins, specifically vitamin C and D, are mentioned. This is partly based on NICE UK guidelines, which include them as an optional part of managing shoulder problems. But the sources discuss their potential relevance more broadly.
How might they help?
Vitamin C is highlighted for potential chondroprotective effects. It's an antioxidant. It might help reduce programmed cell death, apoptosis, in cartilage cells. And some studies suggest it can stimulate the production of key cartilage matrix components like aggrecan and type 2 collagen.
So potentially boosting the cartilage's own repair capacity?
That's the theory. A study by Wang from 2004 is cited, which linked higher vitamin C intake to a 3-fold decrease in OA incidence and also pain reduction in people with hip or knee OA. The sources suggest these findings might be relevant, even if direct evidence specifically for the shoulder, for instance, is less robust. Vitamin D is also important for bone health generally, which is relevant given the subchondral bone changes in OA.
Okay. And rehabilitation, that must be central, especially after an injury or surgery.
Absolutely vital. Using the example of post-shoulder surgery recovery, a structured progressive rehabilitation program is essential.
What are the goals?
Initially, to regain range of motion safely and prevent stiffness or scarring. Then, to progressively strengthen the key stabilizing muscles, like the rotator cuff and the muscles around the shoulder blade. And finally, a gradual, controlled return to normal activities and potentially sport. Full recovery often takes a significant amount of time, maybe 4 to 6 months, or even longer.
There's also that ongoing debate, particularly after injuries like ACL tears, about conservative management rehab alone versus surgical reconstruction. Do the sources touch on the cost-effectiveness aspect of that?
Yes, they do. Studies have tried to crunch the numbers on this. Some analyses, like one by Mather and colleagues cited, which used data from large cohort studies like Moon and Canon.
Okay.
They found that ACL reconstruction appeared to be more cost-effective than rehabilitation alone when measured in terms of gaining quality-adjusted life years, or QALYs. They even suggested it might offer overall cost savings in the long term. Another study by Lubowitz also supported the cost-effectiveness of reconstruction based on QAL gains.
But it's not unanimous.
Not entirely. A Swedish study mentioned found that while conservative management had lower initial costs, it also resulted in lower QALY gains, particularly when QALYs were calculated based on activity level achieved. So how you measure the outcome can influence the conclusion. They also mentioned specific cost-effectiveness analyses looking just at competitive athletes, where the demands are obviously higher.
And this links right back to our earlier point about mechanical loading influencing inflammation, doesn't it? The sources emphasize that guidelines for returning to physical activity need to consider more than just strength or stability.
Exactly. They need to consider how different activities and the specific loads they involve might be influencing that underlying inflammatory process and the health of the cartilage over the long term. It's not just about whether you can physically do an activity, but what impact that activity is having inside the joint at a biological level. High impact might feel okay initially, but could potentially be driving low-grade inflammation, whereas lower intensity loading might actually be beneficial for joint homeostasis.
A really important consideration for long-term joint health. Moving on to injection therapies. These are less invasive than surgery and seem to be very widely used for symptom control.
Yes, they play a major role in OA management. Corticosteroid injections, steroid jabs, are very common for managing pain and symptom flare-ups. The sources note that using imaging guidance, like ultrasound, to ensure accurate placement improves the results.
But there are downsides.
Yes, a significant caveat is mentioned repeatedly. The potential for corticosteroids, especially with the repeated injections, to have harmful or deleterious effects on the cartilage itself. This is a particular concern in younger, more active patients where preserving cartilage health long-term is paramount.
Okay. What about hyaluronic acid injections, viscosupplementation?
Hyaluronic acid, or HA, is a natural component of the synovial fluid in our joints. It provides lubrication and shock absorption gives the fluid its viscosity.
And that's reduced in OA.
Yes, in OA, the concentration and the quality, the molecular weight of HA in the joint fluid are reduced. So these injections aim to supplement that, to restore some of that lubrication, and potentially have some mild anti-inflammatory or pain-relieving effects. It's primarily seen as a symptomatic treatment, though.
And platelet-rich plasma, PRP, that seems to be increasingly popular.
PRP is another option. It involves taking a sample of the patient's own blood, spinning it down to concentrate the platelets, and then injecting that platelet-rich plasma back into the joint.
What's the thinking behind that?
Platelets are packed with growth factors and other signaling molecules. When injected into the joint, they release these factors, which are thought to influence the joint environment, potentially reducing inflammation, promoting some healing responses, improving symptoms and function.
Does it work?
The sources suggest PRP can have positive effects on joint homeostasis, reducing symptoms, improving function, and perhaps delaying the need for surgery in some patients. There's a note that it seems to work better in joints with earlier stages of degeneration rather than advanced OA. A meta-analysis is cited evaluating its effectiveness, particularly for knee cartilage problems and OA.
Okay, so those are mainly managing symptoms, but there's huge interest now in approaches that might actually regenerate tissue or fundamentally change the disease process. Biologics, like cell-based therapies. The sources delve quite deeply into mesenchymal stromal cells, or MSCs.
Yes, MSCs, sometimes called mesenchymal stem cells, are a major focus of regenerative medicine research for OA.
Mm.
These are cells that can be isolated from various tissues in the body.
Where do they come from?
Lots of places. Bone marrow is a common source. Also adipose tissue, fat, the synovial membrane lining the joint itself, even umbilical cord tissue, dental pulp. The list is quite long.
Are they all the same?
And that's a critical point the sources make right away. MSCs derived from these different tissues are not equivalent. They have variations in their properties, their surface markers, their differentiation potential. This inherent variability makes comparing results from studies using MSCs from different sources quite complicated.
Right. How are MSCs actually thought to help in an osteoarthritic joint?
Well, there are potentially a couple of main mechanisms. One is their potential to differentiate, to turn into other cell types, like chondrocytes, cartilage cells, or osteoblasts, bone-forming cells. So theoretically, they could help rebuild damaged tissue directly.
But is that the main way?
Increasingly, the evidence points towards their paracrine effects being the dominant mechanism,
Paracrine.
meaning they work by signaling to other cells. MSCs release a whole cocktail of bioactive molecules, growth factors, cytokines, and importantly, extracellular vesicles, including exosomes.
Exosomes. Tiny packages.
Exactly. Tiny membrane-bound packages containing proteins, RNA, lipids. These secreted factors are thought to have powerful effects on the surrounding joint tissues, calming inflammation, immunomodulation, promoting tissue regeneration, reducing pain, analgesic effects. It's this communication with the existing joint cells that seems key.
Have clinical trials actually shown that injecting MSCs can regenerate cartilage in OA patients?
Clinical trials using intra-articular, meaning injected into the joint MSCs, are still relatively limited in number and scale. And the evidence for true, robust articular cartilage regeneration that you can clearly see on an MRI scan has been variable. It's not consistently demonstrated yet.
But any promising signs?
Yes. One study specifically cited in the sources did report not only improved function and reduced pain, but also reduced cartilage defect size.
Yeah.
And encouragingly, evidence of hyaline-like cartilage regeneration on MRI after injecting adipose-derived MSCs into osteoarthritic knees. So it is possible, but maybe not guaranteed.
Are there ways to enhance their effect?
The idea of combining MSCs with other things like supportive biomaterials or carriers, perhaps PRP, fibrin gel, or hyaluronic acid, is being actively explored. The hope is that these might help the MSCs stay in the joint longer, survive better, and potentially promote their matrix-producing activity, enhancing the therapeutic benefit.
What about practical things like how many cells to use or when to inject them?
That's still largely unknown. Dose-response relationships have been observed in some studies suggesting more cells might be better up to a point, but the optimal cell number, the best timing for injection, how soon after injury or at what stage of OA, and how often injections might be needed, these are all significant unanswered questions.
But is there any consensus on timing?
A key takeaway from the sources is that MSC therapy is likely to be most beneficial when applied as early as possible after a joint injury or in the early stages of OA development.
Why early?
The rationale is to intervene before extensive irreversible damage has occurred. The idea is to use the MSC's immunomodulatory and regenerative signaling effects to help restore joint homeostasis, calm that early inflammation, and protect the remaining cartilage from further degradation.
Any evidence for that early intervention idea?
A preclinical study in a large animal model, relevant because their joints are more similar to humans, supported this. They injected specifically selected adipose-derived MSCs into the joint just 4 days after surgically inducing an injury.
And the result?
It prevented the progression of early post-traumatic OA changes. It reduced cartilage degeneration and also lessened the abnormal subchondral bone changes that typically occur after such an injury. That's quite compelling evidence for the potential benefit of very early intervention.
That preclinical finding really is compelling. What about bone marrow aspirate concentrate, BMAC? That's another cell-based approach using the patient's own tissue.
Yes, BMAC is produced by taking bone marrow, usually from the hip bone, and then concentrating it, typically using a centrifuge.
What's in it?
It contains a mixed population of cells naturally present in bone marrow platelets, various types of immune cells, lymphocytes, monocytes, granulocytes, progenitor cells, and importantly, a small proportion of MSCs and hematopoietic stem cells, HSCs. The concentration process typically increases the total number of nucleated cells several-fold compared to the original bone marrow aspirate.
And how is it being used for early OA?
BM-Brady has shown some promise in studies for treating early OA and is generally considered safe as it's using the patient's own cells with minimal manipulation. Studies do report reductions in pain and improvements in joint function after BMAC injections.
But are there limitations?
Yes, the sources highlight some major limitations. Firstly, whether BMA truly leads to tissue regeneration is still unresolved. Secondly, the results reported in studies vary quite widely in terms of efficacy.
Why the variability?
It likely points to a real need for standardization in how the BMA is processed, which technique is used, and importantly, the final dosage or cell concentration injected. A big challenge is that many published clinical studies unfortunately don't report the specific cellular composition or concentration of the BMAC product they used.
Making it hard to compare studies or know it actually works?
Exactly. It makes it almost impossible to compare results properly or to figure out what might be a minimum effective dose or the optimal composition. And as with MSCs, longer-term follow-up studies are definitely needed to understand the exact effects of BMAs on disease progression over many years.
So again, potential, but still a lot of unknowns and a need for more rigorous, standardized research. What about using fat cells more directly, perhaps without expanding them in a lab first?
The sources briefly touch on these less processed adipose-derived cell preparations, things like stromal vascular fraction, or SVF, which is a mix of cells isolated from fat tissue, or microfragmented adipose tissue, sometimes called new fat or lipogyms.
Any evidence for these?
Research, particularly some promising animal studies, for example in dogs with OA, shows potential benefits. One study cited using microfragmented adipose tissue reported improvements in function, reduced pain, and fewer symptoms lasting for at least 6 months after injection.
How are they thought to work?
The suggested mechanism again seems to be primarily via pair-crane effects, analgesic, pain-relieving, anti-inflammatory, and trophic, providing nourishing factors, activities from the cells within the fat tissue. The resulting repair tissue observed wasn't typically normal hyaline cartilage, again suggesting the action is mainly through signaling rather than the fat cells directly turning into cartilage.
Okay. Another cutting-edge area mentioned is using just the signals themselves, MSC-derived extracellular vesicles, or EVs.
Yes, this is an exciting but very early-stage field. EVs, particularly exosomes, are those tiny packages released by MSCs that carry many of the signaling molecules responsible for the therapeutic paracrine effects.
So the idea is to deliver just the message, not the whole cell.
Exactly. To harness the therapeutic potential without needing to inject living cells, which might overcome some challenges related to cell survival, sourcing, and consistency.
But there are challenges with EVs, too.
Significant challenges, yes. The sources point out that characterization is difficult. While there are some general pan-EV markers like CD9 or CD63, there isn't a single unique marker to identify specific therapeutic EVs, and distinguishing potentially helpful EVs from other microvesicles or cellular debris is complex.
And getting them to the right place.
Biodistribution is another issue. Once injected into the joint, where do they go? How long do they stick around? Their fate is largely unknown, and there's potential for them to be cleared quite rapidly from the joint space, limiting their effect. So, lots of potential, but many hurdles to overcome before EV therapy becomes a clinical reality.
And looking even further ahead, perhaps, induced pluripotent stem cells, iPS cells.
iPS cells represent another frontier. These are adult cells, like skin or blood cells, that have been reprogrammed in the lab back to a very early embryonic-like pluripotent state, meaning they can potentially develop into any cell type in the body.
How might they be used for cartilage repair?
The hope is that because they start from such an early stage, they could be directed to differentiate into chondrocytes that might integrate more effectively into the native cartilage defect, potentially mimicking normal cartilage development better than cells derived from more mature sources.
Is this being tested?
Research is still in the early phases. The sources mentioned studies exploring different protocols to guide iPS cells towards becoming cartilage cells, using specific growth factors, co-culture systems, etc. There's debate about the best initial cell source for reprogramming. Peripheral blood or umbilical cord blood are mentioned as being easily accessible.
What about safety? Is there a risk of tumors with pluripotent cells?
That's always a key concern with pluripotent cells. However, the sources specifically note that the studies mentioned did not report any teratoma or tumor formation, which is obviously crucial for safety.
But it's still a long way off clinical use.
Very much so. The sources suggest that while certain lab protocols look promising preclinically, much more in vivo work in animal models and eventually rigorous clinical trials are needed before iPS cell-based therapies could even be considered for treating OA in patients.
Okay, that's a fascinating overview of the non-surgical and biological approaches, from established treatments to the very cutting edge. The sources also detail various surgical interventions, particularly relevant for focal cartilage defects or perhaps more advanced issues, even in younger people sometimes. Let's start with cartilage restoration techniques for those localized defects. Microfracture is a common one.
Yes, microfracture is a well-established technique. It involves creating small perforations, essentially drilling tiny holes, through the base of the cartilage defect into the underlying subchondral bone.
Why drill into the bone?
The idea is to allow blood and bone marrow elements, including progenitor cells, potentially some MSCs, and growth factors, to seep into the defect and stimulate a healing response.
What kind of tissue forms?
It typically results in the formation of fibrocartilage repair tissue. This isn't the same as the original hyaline cartilage. It's mechanically inferior, more like scar tissue, mainly composed of type I collagen instead of the normal type 2. But it does help to fill the defect, provide some covering for the bone, and the theory is it might protect the surrounding healthy cartilage from further damage or overload.
Is it used for early OA?
It's primarily established for treating smaller, contained focal cartilage defects, particularly in younger, active patients. It has been investigated for early OA, perhaps where there's a significant focal lesion driving symptoms, and reasonable midterm outcomes have been reported.
What about techniques that aim for better quality repair tissue, more like the original hyaline cartilage?
That's where techniques like autologous chondrocyte implantation, ACI, or its more modern matrix-assisted version, MACI, come in. This is usually a two-stage procedure.
2 stages.
Yes. In the first surgery, a small biopsy of healthy cartilage is taken from a less critical area of the patient's own knee. The chondrocytes from this biopsy are then isolated and grown, expanded in number, in a laboratory over several weeks.
Okay. And the second stage?
In the second surgery, these cultured chondrocytes are implanted back into the cartilage defect. In ACI, they're typically seated onto a biological scaffold or membrane, which is then secured into the defect, often covered with a patch.
And this produces better cartilage.
The goal, and often the result, is the formation of hyaline-like cartilage, which is biomechanically superior to the fibrocartilage from microfracture. ACI is generally used for larger defects, say over 2 to 4 square centimeters, and particularly in certain locations like the patellofemoral joint behind the kneecap. Long-term patient satisfaction rates are generally reported as being quite high.
What are the downsides?
Well, it's 2 surgeries, which means more recovery time and cost. And a major challenge highlighted in the sources is the very intensive and prolonged rehabilitation required afterwards. Getting quadriceps muscle strength back in particular can be a real struggle and can take up to a year or even longer. New rehab strategies like high-intensity training or blood flow restriction therapy are being explored to try and address this muscle weakness issue. Like microfracture, ACI is also being investigated for its potential role in treating specific situations in early OA.
Okay. What about using donor tissue instead? Osteochondral allograft transplantation.
Yes, an osteochondral allograft involves transplanting a cylinder or block of mature hyaline cartilage still attached to its underlying bone, taken from a deceased donor.
What are the advantages of using donor tissue?
Several key advantages. Firstly, it's usually a single-stage procedure, unlike ACI. Secondly, it immediately fills the defect with mature, structurally sound tissue. Thirdly, there's no need to harvest tissue from the patient's own healthy joint, avoiding donor site morbidity. It's also very versatile. It can be used for defects of almost any size, including very large or complex ones, and it's particularly useful for situations involving bone loss or abnormalities in the subchondral bone, or complex shapes like on the patella.
Any other benefits?
A really interesting point made in the sources is that it's effectively a denervating technique. Because you're replacing the damaged, potentially painful subchondral bone along with the cartilage, patients often experience immediate pain relief from the procedure itself, which can be quite dramatic compared to techniques that rely on stimulating biological repair over time.
That's significant. Is it used for early OA?
It's being investigated for both early OA, especially with larger or deeper lesions, and for complex chondral problems that might not be suitable for other techniques. Research looking at the outcomes using refrigerated fresh allografts is mentioned.
So a range of options for fixing localized cartilage damage, each with its own pros, cons, and indications. The sources also cover osteotomy procedures, bone realignment surgery.
Yes, high tibial osteotomy, or HTO, is specifically mentioned. This is a procedure typically used to correct bow-legged alignment or varus deformity in the knee.
How does it help OA?
By cutting and carefully realigning the upper part of the tibia, shin bone, it shifts the main weight-bearing axis of the leg away from the damaged intermedial compartment of the knee onto the healthier outer lateral compartment. This offloads the worn area, reducing pain and potentially slowing further degeneration.
Is it done alongside cartilage repair?
Often, yes. HTO can be combined with cartilage restoration procedures like microfracture, ACI, or allograft transplantation if there's a significant cartilage defect in the overloaded compartment. Studies looking at these combined procedures generally report reliable improvements in function over the medium to long term. One systematic review cited found favorable results, although conversion to a total knee replacement was still necessary in a small percentage of patients down the line, around 7% at about 6 years follow-up in that review.
So it can delay or avoid knee replacement for some.
That's the goal, particularly in younger, more active patients with unicompartmental OA and malalignment. The sources correctly point out, though, that more studies with control groups are needed to really understand the added benefit of performing cartilage restoration at the same time as the osteotomy versus doing the osteotomy alone. They also briefly mention the potential for subchondral drilling or other techniques to possibly stimulate cartilage regeneration after the opposite type of osteotomy, valgus osteotomy for knock knees.
Okay, let's switch joints now and move to the shoulder. The sources discuss shoulder arthroplasty, shoulder replacement surgery. This seems more for advanced OA, but perhaps considered in younger patients too.
Yes, the management pathway for shoulder arthritis mirrors the knee in many ways, starting with non-surgical options like physio, medication, injections. But surgery often becomes necessary for significant pain and loss of function. The sources specifically defined dislocation arthropathy as arthritis that develops as a consequence of previous shoulder instability, highlighting again how mechanical factors, like recurrent dislocations, can directly lead to cartilage breakdown and OA in the shoulder joint.
For younger, more active patients needing surgery, is total shoulder arthroplasty, TSA replacing both the ball and the socket, generally preferred for the best function?
Often, yes. TSA is frequently the preferred option for primary glenohumeral OA, arthritis of the main ball and socket joint, in active higher demand patients, provided their rotator cuff tendons are either intact or can be reliably repaired at the same time. When successful, TSA can offer significant improvements in both pain relief and range of motion.
But there are risks.
A major risk highlighted is instability, especially if there are medium or large rotator cuff tears present. The sources state that about half of patients who have significant rotator cuff tears managed alongside a TSA end up needing revision surgery. There's also a trend mentioned towards performing TSA as an outpatient procedure in carefully selected younger patients, potentially saving costs, but patient selection based on age, BMI, other health conditions, and crucially, having good support at home is absolutely critical for safety and success.
A big question for younger patients must be, how long do these shoulder replacements actually last, especially if they're active?
That is indeed the challenge. While TSA generally offers the best functional outcomes, the potential for the implant components, particularly the plastic socket, glenoid, to wear out or loosen over time is a real consideration, and this risk is likely higher in more active individuals who place greater demands on the joint. One study cited found a survivorship rate of the implant of around 62.5% at 10-year follow-up for patients under the age of 55.
So nearly 40% needed revision within 10 years in that group.
In that particular study, yes. It indicates that while TSA can be very effective, the need for revision surgery within a decade or two is a distinct possibility for younger active patients, and that needs to be part of the conversation.
And return to work or sport must be a huge factor for this demographic.
Absolutely crucial. It's often a primary goal. The sources cite a meta-analysis looking at return to play after different types of shoulder replacement. It showed higher rates after TSA. Over 90% were able to return to some form of sport.
That's high. Right.
Compared to reverse shoulder arthroplasty, RSA, or hemiarthroplasty, just replacing the ball, which were both around 70%. And importantly, nearly 80% of those returning after TSA were able to get back to the same level of play they enjoyed before their shoulder problems became severe.
Any specific examples?
High return rates to sports like golf after TSA are given as an example, often 90, 100%, with lower rates typically seen after RSA or hemiarthroplasty. However, a key point emphasized is that there are currently no clear evidence-based guidelines on exactly how long patients should wait before returning to demanding activities or sports. This needs to be highly individualized based on their progress with regaining stability, strength, range of motion, and proprioception, their sense of joint position.
The sources also get into some of the specific technical challenges surgeons face, like dealing with bone loss on the socket side, the glenoid.
Yes, they discuss the Walsh classification system, which categorizes patterns of glenoid wear and bone loss in OA. They note that certain patterns, particularly those with significant bone erosion on the back of the socket, type B glenoids, are associated with higher rates of complications and the need for revision surgery after TSA.
How do surgeons address that bone loss?
Various strategies are used. For smaller defects, sometimes asymmetric reaming selectively shaping the remaining bone can work. For larger defects, bone grafting or using specialized augmented glenoid components with built-in wedges or steps might be necessary to restore the joint line and ensure stable fixation. However, the sources note that the results with some of these specialized augmented components are only moderate, with variable reports of loosening or revision rates.
Okay. What about in reverse shoulder arthroplasty, RSA? That's used more when the rotator cuff is badly damaged, right? Is stability a concern there too?
Yes, RSA is typically used when the rotator cuff is deficient and can't be repaired, as it relies more on the deltoid muscle for function. Stability is still critical. The sources discuss design features and surgical techniques aimed at enhancing stability in RSA, such as using an inferior eccentric glenosphere that's the ball component placed on the socket side in an RSA. Placing it slightly off-center and low helps prevent impingement or notching, where the arm bone implant rubs against the scapula, and it also improves stability by increasing the compressive forces across the joint. Placing the baseplate component as low as possible on the glenoid is also recommended for stability.
Any other techniques?
Biomechanical studies cited suggest that tilting the glenoid component slightly downwards, about 15 degrees, also maximizes these compressive forces and reduces the risk of dislocation. They also touch on the role of the subscapularis muscle.
The one at the front.
Yes, the subscapularis is vital for preventing anterior dislocation after a standard TSA. Its role in RSA might be less critical, especially with certain lateralized RSA designs where the deltoid muscle provides more inherent compression, but it's still often repaired if possible.
Speaking of the subscapularis, managing it during the surgical approach for a standard TSA seems really important for the outcome.
It's absolutely critical for the stability and function of the final replacement. The sources discuss the different ways surgeons can handle the subscapularis tendon to get access to the joint. Sometimes it's cut transversely, tenotomy, sometimes peeled off the bone, peel, or sometimes a piece of the bone where it attaches is cut and later repaired. Lesser tuberosity osteotomy, or LTO.
Is one method better?
Some biomechanical studies suggest the LTO might provide the best strength and stability after repair, although this isn't universally agreed upon, and healing can sometimes be an issue. What is crucial, regardless of the method used, is achieving a strong, reliable primary repair of the tendon or bone fragment at the end of the surgery. Failure of this subscapularis repair is a common reason for pain, weakness, instability, and potentially needing reoperation.
Are there ways to avoid cutting it at all?
The sources also mention a subscapularis sparing surgical approach. The idea here is to work around the main tendon, often by splitting fibers rather than detaching it completely. This potentially avoids the problems associated with repair failure and tendon degeneration, and might allow for faster rehabilitation by preserving the upper, most functionally important portion of the muscle.
Interesting. Beyond instability and managing the surgical approach, what are the other common complications discussed for shoulder replacement?
Aseptic glenoid loosening, meaning the socket component coming loose without any infection being present, is highlighted as the most common reason for needing revision surgery after an anatomic TSA.
Why does it loosen?
It's often attributed to repetitive, uneven forces across the joint, causing micromotion at the implant bone interface, leading to wear debris and eventually loosening. This is sometimes called the rocking horse phenomenon. Seeing radiolucent lines or gaps around cemented implants on X-rays can be an early sign, although using newer, more wear-resistant plastics like highly cross-linked polyethylene, XLPE, seems to reduce this risk. The debate between different socket fixation designs, keeled versus pegged, is mentioned, with large registry data suggesting similar revision rates nowadays, likely due to modern cementing techniques and better materials. Loosening is influenced by many factors: the patient's bone quality, the surgeon's accuracy in positioning the component, the implant design itself, and the forces the patient puts across the joint.
Infection is always a risk with joint replacement too, right?
Yeah.
Paraprosthetic joint infection, PJI.
Yes, PJI is another serious complication, and it's critical to diagnose it accurately if a shoulder replacement isn't performing well. The sources refer to established diagnostic guidelines, like the International Consensus Meeting, ICM 2018 criteria for shoulder PJI, which use a combination of major criteria, like seeing pus or having multiple positive cultures, and minor criteria, like elevated inflammatory markers in blood or joint fluid, to classify the likelihood of infection.
How is it treated?
Treatment is challenging. Antibiotics alone are usually insufficient because bacteria can form protective biofilms on the implant surface. Trying to keep the implant while just cleaning out the infection surgically, debridement and retention is debated, with limited strong evidence supporting it routinely, although it might be considered in very specific acute situations. Often, more complex revision surgery involving implant removal is needed.
Fractures around the implant are also mentioned.
Yes. Paraprosthetic humerus fractures, breaks in the upper arm bone around the stem of the implant, are a known complication. Classifications exist to help surgeons decide on treatment. Fractures where the implant itself has become unstable typically require complex revision surgery to fix both the fracture and stabilize or replace the implant. Prevention is key here, emphasizing careful preoperative planning to choose the right implant size and meticulous surgical technique, especially during revision surgeries, to avoid weakening or damaging the bone. Even after a fracture heals surgically, patients often have some lasting functional limitations, particularly with range of motion. Finally, the sources briefly mentioned using arthroscopy keyhole surgery after a shoulder replacement has already been done. Is there a role for that? Potentially. Yes, in very selected circumstances. Arthroscopy might have a limited role in managing certain issues after arthroplasty, like persistent pain, stiffness, or limited movement that hasn't responded to rehabilitation, provided that infection and problems with the implant components themselves, like loosening or instability, have been confidently ruled out.
What can be done arthroscopically?
Procedures like releasing scar tissue, capsular release, or removing adhesions, lysis of adhesions, can sometimes be performed using keyhole techniques. Studies looking at this are limited, but successful outcomes have been reported in carefully chosen patients where the underlying problem is soft tissue restriction rather than an implant issue.
And one last thing on surgery. How is technology like computer navigation or patient-specific guides changing shoulder replacement?
These technologies, things like preoperative planning software, using CT scans, 3D printed patient-specific instrument guides, PSI, and real-time computer navigation systems used during surgery, are definitely being adopted to try and improve the accuracy of placing the components, particularly the glenoid socket, in both TSA and RSA. They help surgeons achieve the planned orientation and position more reliably.
Does better accuracy mean better results for patients?
Well, that's the crucial question. And the sources point out that there is currently little direct evidence to definitively prove that this increased surgical accuracy actually translates into improved long-term implant survival rates or better functional outcomes for patients. It makes intuitive sense that it should, but the high-level evidence isn't quite there yet.
Interesting. Are there limitations to the current planning tech?
They also note a limitation in most current planning software. It mainly focuses on the relationship between the ball and socket implants themselves. But the shoulder's actual functional motion is complex and heavily influenced by the movement of the shoulder blade on the rib cage, scapulothoracic motion, and other factors outside the joint like posture or spinal curves. Ideally, future planning tools need to incorporate these broader factors for truly comprehensive, patient-specific surgical planning.
That's been a really comprehensive deep dive into the whole landscape of early OA. We've gone from its subtle beginnings in complex biology right through to its significant personal and economic impact and the wide range of current and future treatment approaches. As we start to wrap up, let's just summarize some of the big challenges and perhaps the most promising areas for the future that emerged from these sources.
Well, the challenges are certainly significant, aren't they? Diagnosing early OA reliably is still tough because it's often clinically silent or symptoms are nonspecific. The underlying pathology is clearly a complex mix of inflammation, altered mechanics, and cellular dysfunction. Treatment outcomes are still quite variable, and there's a real urgent need for standardization, particularly for the newer biologic therapies like MSCs or BMA, so we can actually compare results properly. And of course, surgical options, while powerful, come with inherent risks, limitations, and the particular challenge of achieving long-term durability in younger, more active patients.
But despite all those challenges, the research definitely offers some promising directions forward, doesn't it?
Absolutely. The potential of biologics, particularly MSCs and perhaps eventually their EVs, to truly modify the disease process rather than just treating symptoms is incredibly exciting, although much more rigorous research and well-controlled clinical translation are clearly needed.
What else looks promising?
ongoing work that continues to clarify the specific inflammatory pathways involved and understanding the precise effects of different types and intensities of mechanical loading on joint tissues. These offer potential targets for new drug developments, or perhaps more immediately, more refined and biologically informed rehabilitation strategies. Improved surgical techniques, materials, and planning tools also continue to evolve, always aiming for better longevity and function. And although it's still in very early stages, the gene therapy research mentioned, aiming to perhaps deliver therapeutic molecules like IL-1 inhibitors directly and sustainably within the joint, represents another potential long-term avenue.
So lots happening at the research level.
Yes, but the crucial next step, as always, is translating all this promising basic science and preclinical work into practical, effective, and accessible treatments for patients. And that requires developing better tools to identify at-risk individuals early, refining our outcome measures, and running large, well-designed, long-term clinical trials.
And finally, just bringing back to you, the listener, navigating your professional life, how does understanding this really nuanced, detailed picture of early OA, the science, the impact, the treatments, how does that tie back to your world?
I think it's fundamental, really. Understanding the why behind early OA, why injuries pose such a significant risk, why it's fundamentally an inflammatory process, understanding the true scale of the economic cost it equips you to make much more informed decisions, both personally and professionally.
In what way?
It's about recognizing potential personal risk. Perhaps if you or colleagues are very active or have sustained significant joint injuries in the past. It's about understanding the potential long-term implications for career longevity if OA develops early. It helps appreciate the critical need for effective early intervention and properly guided rehabilitation strategies, not just letting things slide. And it allows seeing the broader picture of how this condition impacts workforce productivity and healthcare resources. It reframes early OA not just as some distant health problem you might face in old age, but as a relevant professional and societal challenge that requires proactive awareness and engagement right now.
That connection is powerful, thinking of it not just as a joint issue, but potentially a workforce issue. So to quickly recap just a few key insights from this deep dive, early OA is often a subtle, frequently injury-driven condition that's increasingly affecting younger, active individuals. Its underlying pathology is a complex interplay of inflammation and mechanics, challenging the old wear and tear notion. And it imposes a huge economic burden through lost productivity and healthcare costs. While diagnosis and treatment remain challenging and are constantly evolving, promising new biological approaches like cell therapies, alongside refined surgical techniques, offer hope for the future, but emphasize the critical need for continued research and standardization.
A truly dynamic and challenging field indeed.
So given the strong evidence we've discussed today, linking specific mechanical load profiles directly to those inflammatory pathways within the joint, here's perhaps a provocative thought to mull over. How can we fundamentally reinvent rehabilitation and training programs, not just to restore strength or function, but to actively manage and perhaps even interrupt the underlying biological progression of post-traumatic osteoarthritis in those high-demand individuals?
That's a key question, isn't it? Moving rehab beyond mechanics into biology. It could have potentially transformative implications.
If you found this deep dive helpful and informative, please do take a moment to rate and share the show with your colleagues and professional network. It really helps us bring you more of the in-depth analysis you need to stay informed on critical topics like this.